For management of triple-negative breast cancer, especially for patients that have metastatic triple-negative breast cancer, it's an area of major unmet need because these patients have very limited treatment options that are effective. The average survival of patients with metastatic triple-negative breast cancer is in the order of about 18 months, which is much lower than the survival we see for patients with metastatic HER2-positive or hormone-positive breast cancer. So that has led to exploration of several types of novel treatment approaches and targeted agents for patients with triple-negative breast cancer. Veliparib is a PARP inhibitor, and we've known for quite some time now that a good proportion of patients with triple-negative breast cancer have homologous recombination deficiency that is present even if germline BRCA1 or 2 mutation is not present. And homologous recombination deficiency is seen in about 30 to 60% of patients with BRCA wild-type triple-negative breast cancer. And the aim of the trial, S1416, was to see if adding a PARP inhibitor to a platinum-based chemotherapy would improve outcomes for women who have metastatic triple-negative breast cancer, but also have the homologous recombination deficiency, which for the purpose of the trial we defined as a BRCA-like phenotype. There are other studies that have shown that PARP inhibitors do provide benefit to patients beyond germline BRCA1 or 2 mutations, especially in other tumor types like ovarian cancer, prostate cancer. In fact, a couple of PARP inhibitors are now approved for indications beyond germline BRCA1 or 2 for both of those cancers. So the idea for combining this regimen for triple-negative breast cancer was that can we expand the role of PARP inhibitors in breast cancer beyond those that have germline BRCA1 or 2 mutation. PARP inhibitors, especially the ones that have robust PARP trapping activity, cause myelosuppression, and most of our chemotherapy drugs cause myelosuppression too. So those competing toxicities make it hard to combine good doses of PARP inhibitors along with chemotherapy. Veliparib is one of the weakest, is a PARP inhibitor with the weakest PARP trapping capability. Has less myelosuppression compared to some of the other PARP inhibitors that have more robust PARP trapping efficacy. So in a phase 1 study, adequate doses of veliparib were able to be combined with cisplatin chemotherapy without excessive toxicity. So hence, veliparib is one of the PARP inhibitors that can combine with chemotherapy because it has less myelotoxicity. So the phase 2 study that we're talking about is SWOG 1416, and then this trial was designed to assess the impact of addition of a PARP inhibitor to a platinum-based chemotherapy, specifically in patients that did not have germline BRCA1 or 2 mutation, but had homologous recombination deficiency or BRCA-like phenotype, as we defined in this trial. And the trial was unique in the sense that patients could enter the trial without the knowledge of germline BRCA1 or 2 mutation and BRCA-like phenotype, but all of those assessments were done as the trial progressed. That enabled us to put patients into 3 separate groups: patients who had germline BRCA mutation, patients who didn't have the mutation but had the BRCA-like phenotype, which comprised about 40% of BRCA wild-type patients, and the remainder, which was patients who didn't have germline BRCA mutation or also lacked the BRCA-like phenotype. And what we noted in our results that addition of veliparib to cisplatin chemotherapy significantly improved progression-free survival in patients who had BRCA-like phenotype, and also showed a trend towards improvement in overall survival in these patients. We did not see any benefit of addition of veliparib to cisplatin chemotherapy in patients who did not have BRCA-like phenotype, which is consistent with our hypothesis as we were planning the trial. And in terms of safety, we didn't see any new safety signals. The adverse events were mainly hematological. Addition of veliparib to cisplatin increased hematological side effects that included neutropenia, anemia, and thrombocytopenia. So obviously, we're excited about these results, and this is somewhat of a early study, and we need to confirm these findings in a larger randomized phase 3 trial in a biomarker-selected population. What we have shown in this study that addition of PARP inhibitor to platinum-based chemotherapy works only in a certain subset of patients. So the next trial going forward should recruit patients with this BRCA-like phenotype or this biomarker panel. We would need a larger phase 3 confirmatory trial to establish the efficacy of veliparib in these patients. But it certainly opens the door for us to further investigate the role of PARP inhibitors beyond germline BRCA1 or 2 carriers in breast cancer.